I'm Rob,
And I'm Mike.
and this is Let's Get Ethical.
All right, and we're in again. Rob, how you been, bud?
Good, Mike. How are you? How are things on the West Coast today?
They're chilly for me. Yeah, a little cold for
Chilly,
me.
chilly.
A little
Define
colder
define
than I
chilly
like.
real quick. Define chilly real quick for our audience.
65.
Okay, okay. Well, up here in the good old frozen north, we're gonna have -40 down here
So
tonight, Friday into
what's it
Saturday, and
like living in the Arctic?
it's like living in the Arctic. And we're gonna
That's
have an
ridiculous.
awesome New England snowstorm on Sunday into Monday. So it's
If there was
beautiful.
ever a reason to move, I think you've discovered one.
Yeah, yeah.
I'm just
Someday
saying.
I'll get there.
Yeah. So anyway, welcome in everybody
Welcome.
to another episode of Let's Get Ethical. Today we're actually going to revisit an episode really quick. I know we're on our fourth episode here, but as I do, I was on the phone with my friend GR from episode 2 episodes ago, talking about that episode, and GR had was telling me that after reviewing the episode, after taking a look and listening to it and thinking about it and reflecting on it, that he wished he could go back because he had better answers to the questions after taking a few days to think about it. And so we thought, you know what, maybe we should bring him back on.
Yeah, I
And so
like
we
it.
asked quite a few questions, and we got an inside look into what veterans deal with regards to VA care and what caregivers of veterans deal with um, after discharge. And we talked about some ethical scenarios or some ethical responsibilities that we as healthcare providers have.
Yes.
And so we're not going to rehash all of that. If you'd like to see that, please go back and watch episode 2, um, revisit that and take a look at that. And you'll get to know a lot about GR in that episode. But just as a quick refresher, GR is the COO of Operation Sick Care, which is a foundation that he and his brother started to help vets with regards to mental health as well as healthcare. He's also a 2025 Elizabeth Dole Fellow or Elizabeth Dole Foundation Fellow, and he's a full-time caregiver for his brother, Doc Ziggy.
Doc
Um,
Ziggy.
yeah, I want you to go back and look at episode 2. You'll get a whole lot more information. Um, but before we move on, I need to remember to remind everybody that we have an email address. If you have a show idea, you have something you'd like to get in touch with us about, it's letsgetethicalpodcast@gmail.com. And so make sure you have an opportunity. You can also comment down below. But again, we'd also like to ask you to like and subscribe and turn on those notifications to make sure that you get notified of all the new episodes. I keep forgetting to do that, Rob. I keep forgetting to talk about those things in the episode, and we always go, oh, shoot. So trying to remember, trying to be better about it.
Thank you for
How did I
remembering.
do, Rob? Did I do good?
You did much better this time. Very proud of you.
All right, nice. So let's get right into it. Let's go ahead and bring GR on. GR, how you doing, buddy?
I'm doing well, Mike. How? Rob, Mike, how's
Hey,
it going, guys?
JR. Yeah, welcome back, man. We're excited to
Hey,
have you
man.
back today.
Thank you. I appreciate it. And I threw in a Hail Mary request there, and you guys were so open. So it means a lot for me to be back on.
Absolutely, bro. So, GR, why don't you cover a little bit? I covered a little bit just that we were on the phone, but would you kind of describe what we talked about and what happened?
Yeah, absolutely. So like you mentioned, we were kind of rehashing the show and going over it and patting ourselves on the back for a job well done, that kind of thing. And I had asked you, I was like, oh, hey man, there's some things that got my brain brewing after I was reflecting on Rob's question of what can we do better as medical providers. And as I was sitting there, it's kind of those moments where you're sitting there thinking, man, I wish I could have said this. Oh, I had a better answer here. And the bottom line was that I personally felt I could have been more thoughtful in my answer, right? Because I think that helps the both sides of the equation, the caregiver community and medical providers, to get a better understanding of what we really can do better, right? Have
Right.
some starting points for us to have discussions and see what change can be made, if any.
And in looking at it, we felt that I think all three of us felt that that episode was really a good foundational eye-opening episode. And so rather than try to mess around with it, it's better to revisit. And so just in thinking about that with regards to, let's go straight to Rob's question. Um, with that question, what can medical providers do better
Mm.
to help make sure that caregivers are heard, make sure that vets feel as though um, they're being listened to and they're being championed. Championed was one of the words that I wanted to bring back up from our last episode, because it was such a big deal to champion the veteran, champion their journey and or adventure, as you guys call it. Um, how can we do that?
Well, I think first and foremost, before we get to championing the veteran, we need to tie this back to the caregiver, right?
Right.
And
100%.
what we need, what we're looking for as caregivers is to be included in the dialogue, to make sure that doctors and other medical providers are seeing us as really an ace in the hole, right? That person who knows more about the veteran than anybody else. And to be able to take our input and our documentation seriously from the get go, right? And so that would be step one. And some of the, I guess, practical ways to do that are starting to figure out, is there a way a caregiver can introduce themselves to the medical provider in a way that, shows, hey, I'm here to help as well, right? And really share what I've documented, what my experience is, so that the doctor has an understanding. This isn't just a bystander in the office sitting here. So really, what it really starts to do, I think, is to start it creates a triangle. Now you have medical provider, you have your caregiver, and you have your veteran, and you're speaking openly and honestly from the get go about what is in the best medical interest of this veteran and what his goals are. I think that's one of the first places that places we can do better.
Now,
GR, I really like that. Mike, oh, sorry, go ahead, Mike.
oh, go ahead, Rob. Go ahead.
So I really like that word, the triangle. So how many
Oh yeah.
times do you go in with your brother, or even we go in with our spouse and our significant other, and the provider has a lot of conversation, or they're focusing just primarily on, right, us as the patient, or in your case, GR, they're focusing on Doc Ziggy as the patient, but you're sitting there in the room too, and you are providing his care 24/7. So I love that mental picture in my head of, the provider as the tip of the triangle, and then you hear, and all those pieces connecting together. I really like that. I think that's excellent.
Thank you. Thank you.
I was gonna ask. This just popped up into my head right now. Do you feel that, and this is a question really for both of you, Rob and GR, do you feel that maybe it could be a philosophical change that needs to happen? And by philosophical, I mean, as healthcare providers, it's me, the patient, doctor, the patient. Is there a change in the way that we are thinking about specifically veteran care
Mm.
that might improve that, and we go into benefit of the patient, right? That beneficence. But
Mhm.
is there a philosophical change that maybe needs to be brought about, or a different train of thought maybe that we need to have, because every patient is individual, right? And so every patient needs to be treated differently. But it just kind of brings into my brain that maybe it's not just every patient, but each patient population needs to have a different approach.
Hmm.
GR, what do you think about that?
That's a great question, Mike. And now that you got my curious brain spinning up, right? Um, I think you're onto something there. To be quite honest, if I'm putting myself in a medical provider's shoes
Mhm.
and saying, okay, if if I'm to be doing my best work with a human being, maybe I need to not look at this interaction as just a check mark to check off on my list of things I got to do, that I need to be really listening with intent, understanding all of the for lack of a better word, just coming a corporate America word, stakeholders in the room.
Right.
And really identifying what's going on first before I roll into it and start, you know, in my head already just figuring out what notes I'm going to take and what prescriptions I'm going to make, right? And actually listening with intent and understanding the goals and where this person is now and where they want to go. I think that is a philosophical change in thinking.
It, I agree. There is a need for philosophical change. And Mike, I'm glad that we're tying this. Since this is Let's Get Ethical, we're tying it into right one of the substantial pillars of healthcare, which is beneficence. And we think about beneficence, everything we do has to have benefit to the patient, and it has to be what the patient wants, and demonstrate that it's going to make a change. I think one of the things maybe that creates a philosophical change, I'm just going to throw like the use of AI. I think more and more when I go into providers' offices or I have appointments, that they're using apps on their phones and they're using software that records the visit without them having to do a bunch of sitting behind a computer screen. And to your point, I'm clicking off a lot of boxes, but I'm not really listening with intent. I might be listening, but I'm listening to click off a box. And maybe that's the philosophical change as we see more and more automation happen, that allows the provider to have a lot more focus on the patient and the caregiver. GR, what do you think about that from a
So that
caregiver perspective?
Interestingly enough, Rob, I actually just read an article yesterday or the day before that is something that the VA has been piloting. Um,
Wow.
AI inside of the office, and for the very reasons that you brought up, is it enables them to listen with intent. They're not worried about typing and making sure they have all the boxes checked and they're doing it right, within their system. And when I was reading it, um, the techie geeky side of me said that's freaking kind of cool, and the other side of me is going, okay, if the room is listening, who is getting this information, right? How do I know it's staying here? Right. The paranoid part of me is talking about that.
Sure.
And I go through don't get me wrong. I have my Google listening devices and my phone. It all hears me. Right. But internally, I still have that dialogue with myself that, okay, where's this information going? So do I think it is a step in the right direction? I don't know about right, but I think it's a good step forward to try, like to see if that is a help rather than a hindrance. And then we can fight about all the other, privacy things along the way and make sure that we're, do no harm, right?
That's
Are we collecting this? Are we collecting this data, and are we going to now use it against the patient?
right, because Skynet is real.
Yeah, no, you're right. And even though we can, so Mike, a future Let's Get Ethical podcast might be AI use in healthcare. It is
Yeah,
my
ethical.
understanding is that it only records specific aspects of the visit. It
Mm,
doesn't record any side conversations. With that being said, though, GR, let me ask a question,
mhm.
because one of the things that I was thinking about and we were talking about was the expertise of the experience. So it's the provider ensuring that you, as the caregiver, are being listened to and being paid attention to, because you are at that point the subject matter expert of
Yeah.
what has been going on with your brother. And how do those aspects of what you have to say get included, for example, in the body of a visit, to ensure that the next provider that comes along, or the next person that you and your brother have to go visit, can clearly see the value of what you bring to the care of your brother?
You know, that is the perfect next question, to be honest. And thank you for asking that, because as I was reading that article, that is one of the benefits to having AI record these things in an office visit is now it's coming straight from my mouth and my brother's mouth and getting recorded in the EHR. So if it is now recorded in the EHR, the way the VA has worked from the beginning, well, I don't want to, I hate dealing in absolutes, but typically what people will say is if it's not on the record, it didn't happen. Let's take it from that,
Right.
perspective,
We have
right?
And
heard that
really
so
quick,
many times.
some people might be thinking, what is EHR? And it's what you would know as EMR, right? The electronic medical record, or EHR is electronic healthcare record.
Yes,
Just
exactly.
for clarity for everyone.
Absolutely.
Same thing.
Same. So if now one of the benefits I see there is a caregiver who is having issues maybe in getting VA benefits as a caregiver, and they look back into the record and say, oh yeah, it's documented here that this is this person's caregiver. They are doing caregiver work, and this is a legitimate claim. That can now help get caregivers to have more approvals rather than denials. I think that is a big benefit, because of that's the way the VA presently works, right? And I don't see them making any widespread changes anytime soon. So this would be a huge benefit. I think another benefit to that, Rob, is it benefits the VA in being able to get some insight into answering some of the at-home questions. What's going on at home, right? And they're hearing it right from the caregiver and the veteran of if the medical provider's asking, if they have that shift in mindset, and now they're being more thoughtful in their question asking and not just checking off those boxes of what they need to find out, but they're thinking, what's going on at home? And then that gets on the record as well. Then that creates more data for somebody to take a look back and make more informed decisions.
Yeah,
Right?
and we're taught to, from an educational standpoint in healthcare, at least in respiratory care, we teach interviewing styles. Now, while we don't discuss specific questions that you should ask, we do talk about asking open-ended questions to encourage the patient, or in this case, the caregiver, to give their take on the response rather than leaving it at a yes or no, or a closed-ended question. But we never talk about any specific questions that someone should ask. But in this case, are there specific questions that you feel should be addressed?
Absolutely, because when you're in a veteran situation, veterans don't like to tell the truth, the whole truth, and nothing but the truth, for a lot of various reasons. Okay. And so when a caregiver is in a situation where they can provide added context to what's really going on at the home, what I've started calling that is the shadow file, right? It's the file behind the scenes that the caregiver has at their fingertips, because they're watching 24/7. For instance, my brother the other day shared some information that's been going on with him for a while now, based off of a dish that we serve for dinner that is on our regular rotation. And when we have that dish, I've been noticing over the past few months that he only eats about half of it. And he never brought, until I don't know, about 4 or 5 days ago, he brought up the fact that, have you ever noticed that I don't eat this because the texture drives me crazy? And when I try and scoop it up with the fork, my hand starts going crazy and stuff falls off. And then I start getting tense, and I can go into an episode. I go, I didn't know all that other stuff was happening, but I did notice that you were not eat when we have this particular meal, that you do not eat at all. Right. So
Right.
caregivers are trained, or they're not trained. They actually pick up on these types of patterns,
Yeah, they become
and
accustomed to it. Yeah.
they become accustomed to look for those
Right.
patterns. So being able to take that information, put it in your file, and then share it with the doctor, that's the shadow file. All those little weird, what might be anecdotal things, right, that we don't think about. And that's the reason why, to answer your question, Mike, of why in this instance there should be specific questions that could be answered, or at least a line of thinking to
Mhm.
start to draw that information out, is vital, is because veterans aren't going to tell you everything. I mean, just like, look,
Yeah.
as we get older, do we necessarily want to tell everybody what our real age is? Some people do, some people don't, but it's that same type of thing, right?
Some of
Um,
us wear it on our face.
Yeah.
yeah, you, you totally understand. Um, but that's basically what it comes down to, right? Is, and especially when you're in a setting where you're already on guard that if I say the wrong thing, the doctor might not let me do this, or tell me that I need to take away that.
Mhm.
And veterans, when they have these issues, are acutely aware of that. If I say the wrong thing, are they going to say that I'm not stable enough to have a firearm?
Oh,
Those types of
Yeah.
things, right?
Yeah. Right. Right. So that's an interesting point. That so one, like, amazing that that your brother, and how long had that been going on for? Just out of curiosity.
Months,
Months.
months.
Months. And you noticed, right? You may have noticed the subtleties, and maybe at first you didn't put two and two together. And then
yeah.
your brother brings up, "Hey, did you notice that when we eat this meal, 1, 2, 3 happens to me?" And to your point, right? He didn't want to talk about it because, to your point, you go in and you have this conversation with the provider, and suddenly something has changed. And I'm gonna tie this into one of our pillars in ethics is autonomy.
Mm,
And
Yeah.
now, does this potentially negatively affect? And I know this is, again, probably I'm reaching, but could that verbiage, to your point, all of a sudden change the person's right to moral autonomous decision making?
it's a good question.
Who's to say, right? Who's to say? Who's to say? I'd like to, if I could, put your toe into the water for something different for a second as we
Sure.
continue. When you take your brother in for his appointments, I'm just really curious about this. How are you identified in his medical record as his primary caregiver? Is there
I am
any identification?
100% sure. Sorry about that.
No,
I
that's
am not 100% sure what it looks like on the medical record. Um, I do know that when we do go into a visit and it is a new provider, that is the very first thing Doc and I cover. He throws up and says, anything you have to say, make sure it's said to my brother,
Mhm.
because he's my eyes, my ears, and my brain. Whether they document that or not in the system, I do not know.
Yeah, because I think, Mike, you can agree. We've worked in healthcare for 30 years, and we see things: emergency contact, DPOA, next of
Mhm.
kin. But there really isn't, as far as I was thinking today about this, that there's any way to really show in the chart, with the exception of going through the note, that this person is the primary or the sole caregiver
Yeah,
until
I
the
don't know.
question
Right.
until the question gets asked. Is there an opportunity, GR? Do you think that's an opportunity for the people out there who are designing electronic medical records?
I I think that is an absolute opportunity, right? I mean,
Yeah.
as you say that, I'm thinking, well, yeah, if that would make it a lot easier for me, right? If that is something that is top of mind for me and the provider and the industry, that's huge, right? Because
Mhm.
l- as humans, behavior is what rules us, right? And I'm not going to be able to go in and change somebody from not checking boxes, right? We can mitigate that with some of the things that we just talked about. But if I've been checking for boxes for 30 years, that's still going to be a part of my behavior. So if
Right.
we add that to the record, that is a huge opportunity.
Yeah, and it can be made easy to find in the medical record.
Yeah, it should be right
So,
there, right? I
yeah,
agree. This is one of those top areas where we should be able to identify right off the bat who the primary caregiver is. It makes me think back to the days, when I worked in the pediatric ICU, and we had a lot of chronically ill kids, but you knew who the parents were. The
right,
first people you talked to were the parents. Hey, what's been going on at home? Tell me how things have been. What have you seen? What's been going different? Because they're the primary caregivers. I was thinking
right.
about that as we're having this conversation. It doesn't even give me a pause that I wouldn't want to talk to the parents and get exactly what was going on.
Yeah, exactly. And
Yeah,
I
and
think, go
I'm
ahead,
sorry.
Mike.
I
No,
was
no,
just going
go.
to say it's because it's because we're trained to be that way. We're trained to
Mm,
in our programs, and whether you're a nurse, a physician, or a respiratory therapist, whatever, we're trained that in a neonatal pediatric setting, the parents are the surrogate decision makers, right?
Correct.
They're the ones
Correct.
that make the decision. They're the ones that we need to speak to. If a pediatric patient is old enough to give us some information, yes, we'll get it, but we know we're going to get more from that parent, from that, and they're the caregiver. It's the, and I don't mean to compare Doc Ziggy to a pediatric patient, but there's a similarity there, and
yes, there is.
so maybe there's a retraining that needs to occur within the system, that hey, when you have this patient, and it's not just vets, but there's an elderly patients. You have a patient who comes in, you
Yes.
need to involve and create that triangle. You need to find out who is next of kin, who is the caregiver, who is the one that is helping make the decisions, so that they can be informed, so that, because the autonomy in that situation is not just Doc Ziggy, it's you and him.
Yeah.
And so you guys are knowing that you guys are going to go back, and you guys are going to have a conversation between the two of you, and between the two of you, he's going to make the ultimate decision, but you may be the one that is being informed in certain areas that he may or may not be paying attention, because maybe he's closing down, or maybe he's just doesn't have the trust, and so you're listening with a different
Right,
intent than maybe he is. And
right.
so that informed consent, that autonomy,
Mhm.
needs to happen within that triangle that we're talking about forming.
No, that is huge insight right there. I
So
think that
like a retraining needs to occur.
I absolutely, I mean, from your side of the spectrum, if that's retraining, cool. But what you just shared, it really does align with asking ourselves the hard questions of what do we need to do to make this a better experience,
Right.
right?
Yeah.
For and with the ultimate outcome being the goal of the patient or the veteran or whoever it is that's being treated.
Hmm.
I dude, thanks for bringing that up. I mean, now you're not gonna have me on anytime again soon, but that's gonna have me a lot me to think about. And this is what I first of all, this is why I'm grateful for your platform, because having conversations like these, I think, is what can start spurring moving these conversations up to our local leaders, our state leaders, to help start making the right change, through policy, so that we can enable not only caregivers to have a better adventure, because that's the word we're using now in helping their loved ones, but also to help you guys remove some of the obstacles that you deal with, right?
Yeah.
Um, and that can only be done through policy change.
Yeah,
Correct.
for sure.
Yeah, that brings up a really good point, GR, because I think what we're all the three of us are talking about is it's about being inclusive.
Hmm.
It isn't just having a conversation with the patient. Like Mike and I talk about, moral autonomy, and person has to be competent, they have to be capable. Well, we've established that, right? If we have an 8-year-old child and they are not deemed competent to make their own decisions, we're talking to the
Right.
parents. But in these situations, GR, when you're going in with your brother, he's an adult. He is
Yeah.
fully competent and he is fully capable of making his own decisions. And I'm going to throw a caveat in there.
Hmm.
However, it needs to be inclusive, right? There needs to be
Yeah.
shared decision making not just with your brother, because your brother has invited you in to be part of this caregiving, I'm going to call it experience. We'll call it an adventure, caregiving adventure. And there needs to be inclusivity. And how do you think we can do better in healthcare from your perspective of ensuring that these visits and these times where you go with your brother, that it's an inclusive conversation?
You know what? That's a great question. I think that my work with the Elizabeth Dole Foundation um, provides a good part of that answer. And with that, it's being able to integrate caregivers into the treatment planning, right? So that if we start from the end of or the beginning of our conversation and work forward here, it's all of the touch points that we've already talked about, right? So we've identified that this veteran has a caregiver, and now we're integrating them into the conversation, and now we're taking their feedback and their shadow file and implementing into how we're going to plan out um, the different milestones that we need to reach for the ultimate goal,
Right.
right? In
Right.
our case, it was my brother walking again, right? And instead of meeting a bunch of challenges, if we are operating from a place where we can remove as many challenges as possible and treating everybody as a human, and then understanding the family dynamic as well, and the I think even more importantly than the family dynamic first is it starts with this person as a veteran. So
Yes.
all of their thinking is
Right.
from that mindset, right? So it has to start there, include the family, right? And move forward from there. So I think that the Elizabeth Dole Foundation has started that conversation and done a ton of work on doing that. And part of what I'm trying to do as a fellow is expand on that, not only here in California, locally in Southern California, but also, um, you know, raise that awareness and amplify my voice all the way to Capitol Hill.
Absolutely.
Yeah, that's awesome.
Absolutely. And maybe another thing is also um, understanding that while caregivers are not trained professionals, they are doing so much work that is equivalent of a nurse,
Oh yeah.
right?
Right.
So
Yes.
do we Mike, you talked about retraining a little bit earlier, right? And if we're integrating caregivers into the equation, um, at what point do we say, okay, this caregiver needs a certain level of training
Uh-huh.
Mm.
from a professional,
Yes.
right? If they're administering meds, if they're, doing whatever that higher level of care takes, and to ensure that they're doing it right, that is, I think, something that needs to be brought into the equation.
Yeah, no, I'm just sitting here recapping in my brain, um, kind of what we've talked about, and we've hit on it a couple times. It starts with recognizing the patient population, right?
Mm,
And not, I mean, we're talking about vets here, but we're not just talking about vets. We're talking about, like
right.
like we brought up pediatric patients. If I know that this is a pediatric patient, I already know there's definitely a caregiver involved.
Right.
So why can't we start with, if I know that this patient is a vet, there's likely a caregiver involved. And it begins there, and then it starts to trickle down, and we say, okay, so there's likely a caregiver involved, so I need to now form that triangle. Who's the caregiver? Let's get them on record. Let's get them in the medical record. Let's get it documented. Let's make sure that it's very clear, so that when this patient comes in, I know that it's this patient and this is the extension of that patient as a caregiver. And this is where the retraining part that I was talking about kind of comes in, is we have to change that philosophy, change that it's not just me and the patient anymore. Just like in the neoped environment, it's not just me and the patient. A neonatal patient can't tell me anything.
Right.
It's me, the patient, and the caregiver. Um,
Right.
and so we kind of have to begin to recognize that, and that there is a need for a change in that that approach, I'll say.
Yeah, I
Maybe big
love
word.
where you went with that, and I think what you just brought up takes me back to your question of what are some questions that medical providers need to lead with,
Mhm.
and
Mhm.
rather than maybe assuming that there is a caregiver involved, that is the first
The
question to
first
ask,
question. Yep.
right? Is, do you have a caregiver? Do you have somebody that takes care of your medic? And then even like, so because the way my brother said, you have to break it down Barney style for me. So when the doctor's asking that question, do you have a caregiver? They might be like, no, I'm my own guy, right?
Right.
And
Right. Right.
what the F is a caregiver? And so that follow-up when they see the deer in the headlights look might be, well, do you have somebody that helps you with your medication, that helps you
Right.
get dressed and those type,
Mhm.
with your other ADLs when they have that like what the hell's a caregiver?
GR, that was
Um,
oh, man, that's perfect. I mean, that
Yeah.
really that like, that is how many times and I think we're, as respiratory therapists and nurses, we're all guilty of using lingo that fits into, right, our brain and the conversations that we
Yeah.
have with our colleagues. But when the patient gives you the deer in the headlights, you gotta catch it, right? You just said something that they absolutely don't understand.
Yep.
But maybe the leading questions are, I need to make sure that, and it's not about insulting someone's intelligence. It's leading with an open-ended question that everybody can easily refer. I don't even say understand, refer to, right?
Mhm.
that's a
Hey,
great way
is
to
there
frame it.
somebody at home that
Yeah.
helps you? Who at home helps you with your medications? Who at home helps you with your ADLs? Is that
Yeah.
person here today with you? Hey, the next time you come in, we want you to know we welcome you to have that person who is also your ears and your voice to be here with you in the appointment, so that there isn't just one of you getting all this information. There's two sets of eyes, two sets of ears, two brains that are
Absolutely.
absorbing, because we know it can be overwhelming in a visit. I don't know if
Yeah,
you know,
absolutely. Because
right?
and it's funny, that what you said, what you just said, Rob, is resonates with me so personally these days with my
Mhm.
parents. While I'm not my parents' caregiver, they're still going to get their information. I now am, either myself and or my sister are going to every doctor's appointment with them because they're hard of hearing. They don't quite understand what's going on. They're in the midst of it. And so I'm just as a third person there to gather information so that I can then break it down. And as a healthcare provider, I'm able to do that. I can break it down into layman's terms and take some of that jargon that they're hearing. I mean, Rob, my mom heard the word pluridesis the other day, and she had no, and he
Right,
just brushed over it,
right. Like
and
it's
he's like, "Well,
nothing.
we could do a pluridesis," and I'm like,
So
"Oh my
what is
gosh." He goes,
paradesis?
a pluridesis is a procedure that happens when a patient has repeated pneumothoraces or pleural effusions. Now, pneumothorax is when the lung collapses inward and you get air inside the pleural space, which is the space between the inside of the ribs and the outside of the lungs. A
Okay.
pleural effusion is when you get fluid in that same area.
Mm.
And so if it happens repeatedly, a pleurodesis can be done where what they do is they use talc or tetracycline or something like that, which causes an inflammatory response, and it causes the outside of the lung and the inside of the chest wall in that area to adhere to one another.
Mm.
And so it'll never happen again. They call it a pleurodesis, but the layperson has no idea what that means. And I heard this dude say it and I laughed because I'm like, they don't know what you're talking about.
It
I'll
sounds
explain it
scary.
later. Yeah, no, for
Yeah, it
sure.
sounds
Totally.
scary. Right, right, right.
But yeah, it's that kind of a thing. And we have to and we're all guilty of this. I think I'm less so guilty because I do deal with students in their first,
Mhm.
second, third, and fourth semester of a healthcare program. And the first two semesters are really learning a new language, translation. And so I tend to be better at breaking things down. I'll use a big word and I'll say that means this. And
Mm.
so when you hear this, think of this. And so when I tell you this and I use that word, it makes sense. And so we are guilty though in the hospital 90 probably 9% of the time of using jargon, not realizing that the patient has no idea what we're talking about. And And so it needs to be brought down because some of those words do sound scary. And you go, my God, what's going on? Am I going to die? And you're like, no, no,
Right.
actually a very simple procedure. It just has this big,
Yeah.
long, stupid word. You know, it becomes that kind of a thing. So that's one of the things that I know we're also missing in healthcare. With regards to retraining, I'm trying to attack that locally with my students that, hey, when you're with a patient, you can't use these words. You
Right.
have to be able to go over here and talk to the doctor, but then you have to be able to come over here and talk to the patient. And you got to bring it down to a human level
Makes
because you
sense.
have to realize this person might have absolutely no idea what's going on in healthcare and they don't know any of the words you're using. And if they don't, and you don't explain it to them, now you leave them to go look it up on Google. And what does Google always tell us when we search things medically? We
You're
have
gonna die.
Right. Right. Yeah. Fear of dying.
where we go.
Regardless of what Google is saying or what WebMD is saying in your head, I'm gonna die.
I'm
Yeah.
gonna die. I better get my affairs in order. Yeah, seriously. So, just recapping it with all of that, as part of, we need to recognize all of those things, and then we need to take steps to make it more conducive for the patient and caregivers, not just vets, but all caregivers across the board, because they need that, and a large part of that is education. Educating the caregiver on what this means,
Right.
what's going on, and that leads back into informed consent and autonomy, but it also leads back into beneficence.
100%.
Mike, what you just shared actually, if that was going on and that education to the caregiver was going on, the amount of time spent on Google or now in AI,
Mm-hmm.
that the rabbit holes that caregivers go down trying to
Yeah.
figure out on their own, if we can minimize that level of stress and the time
Right.
it takes to go down that rabbit holes, that would be huge.
Absolutely.
Because I can't tell you how many different websites, papers I've read, define this, define that questions I've asked, and it becomes overwhelming really quickly,
Right.
right? And the other thing is, you're sitting there thinking, why am I doing the doctor's job? Why am I doing the insurer's job? Why, and why can't they be straight with me? Right? Because I already feel like I'm being duped. So now I'm having to go back and do double work just to make sure I'm not being duped. And to close that gap would be a huge burden lifted on a caregiver.
Wow.
Yeah, no,
Wow.
I agree. And I mean, I'm doing it. I'm trying to, if you think of a way that I can attack it on a state or even national level, I'll go attack it. I'll go do it. I'll stand in front of a group, that scares me to death, but I'll stand in front of a group and I
I'll
will
join you,
lay
Mike.
it
I'll
out.
join you. You
All
won't be
right.
alone.
Make me
You
feel
won't be alone.
moral support for each other.
Absolutely. Absolutely.
It's good to have friends in good spaces, because I mean, and Mike, I know you're serious about that.
Yeah.
That you would do that, and
100%.
and Rob, I think the same of you. So that's huge, right? So that we as people just trying to enhance the quality of life and do our jobs better, by having these conversations and then standing behind that by applying it. I can't appreciate that enough from what you guys are doing here again. And I think one more thing from my perspective, and maybe you guys can weigh in on how big of a disruption that is or not, but streamlining the administrative work on the privacy side.
Ooh.
HIPAA's used as an excuse a lot in many
Yep.
different ways. In some instances, yes, it absolutely is a big deal, right? Because that's what we're being governed by. That's what the rules and the laws are now. And
Right.
so be it. But how often do we overextend that to just not have to do something, or so we can go take our lunch break or do whatever, right? And we throw that as an excuse. So, but perhaps from a caregiver's perspective, if I get that paperwork and I'm looking at it and it covers all of the different specialties, and I don't have to redo it every time I get a referral to go to PT physical therapy or neuro or primary care. I'm doing that over and over and over again to reduce that redundancy. That's another thing that's huge.
There's
Yeah, some of
definitely
that stuff should be able to be shared across the board. And I honestly, because I deal with it too. I don't know why it isn't. But I absolutely agree. Rob, I interrupted you. Go ahead.
no, no, you're fine. I don't know that there's a good answer to that level of it's bureaucracy is really what it
Hmm.
is, and a lot
Yeah,
of
it's a
health
legislative thing.
it is, and a lot of
Yeah.
healthcare, as we know, is a bureaucracy. But I definitely think that there needs to be a shakeup. There needs to be the right disruption, right? We can't just disrupt to disrupt. There has to be a disruption to make it better. And GR, when you everything that you say, I can hear the frustration that you
Mhm.
feel
Oh yeah.
as Doc Ziggy's caregiver. Like everything you say, these little bells go off in my head. I'm like, he's right. He's right. He's right. And I think, Mike, even you and I, we just because we work in healthcare, we still use the system, right? We
Yes.
still enter the system and we sit there and go, why is this so broken? And what can we do to fix it? And we feel like we're just one small pebble on a beach. But sometimes all it takes is a small pebble, right, to start rolling to make a huge difference. And
Yeah.
I just want to thank you, GR, again for coming on and joining us and spreading not just your message and the story of your brother. Because again, I have so much respect. I love your brother as a veteran, and I'm a veteran, and I love him for the service he gave. But man, we love you
Yep.
for stepping up and as a brother and a caregiver and everything that you're doing and all the work you're doing with the Elizabeth Dole Foundation. Man, it's just amazing. I don't think we can't thank you enough. And I hope our audience feels the same way when they listen to our episodes of just what an amazing story this is and how many key points that we want to hit on and how every one of these points ties into the ethical pillars. Right. So Mike and I are talking about ethics, and every single one of these has
Yes.
to do with ethics of the family and the patient in the system. So thank you very much.
Yeah. And
Rob,
for your advocacy is the
Yes,
thing.
great
Yeah.
word. Thank you. Great
100%.
word.
Mike, first, Rob, thank you for sharing that with me. It means a lot. It really does, and I can't thank you guys enough. Again, these conversations are going on all over the place, right? And the more we put them out there, going back to your pebble analogy, yes, that we pick up more steam. We put it in people's ears and help them take pause every now and then and say, can we be doing this better?
Mhm.
And then once we get to the point of, well, yeah, absolutely we can. And then we roll that boulder up. It turns into a boulder, and somehow we get it up to Capitol Hill,
Yes.
and the end goal being that we make, to your point, Rob, the right change for the right reasons. And it's not going to be perfect change. Everybody's not going to get everything they want, and there's always going to be something. Um, but at the end of the day, if we're doing it from a place of we're treating human beings,
Hmm.
and this shouldn't be a profit motive. This shouldn't be be done for accolades, but to help the men and women who served in our experience right now that we're dealing with, to have the best quality of life possible. We need you folks out there, standing beside us, like Mike just said, and being able to raise their hands and raise their voices. So I can't
Absolutely.
thank you enough, both of you, for allowing me the time.
You are more than welcome, and thank you again for coming on and helping dive a little deeper. And for those of you, as we close out here, for those of you watching, if you made it this far, as usual, thank you. Um, I'm up in the top corner. I've replaced the logo with a QR code. If you have a vet, you know a vet, you're a caregiver, you know a caregiver, you need some help. Reach out to GR. The links will also be in the description down below. Um, and I'll also put this QR code at the credits as well, so that you guys can get in contact with Operation Sick Care. And I encourage you to help out. I encourage you to get involved where you can. If you're a healthcare provider, the change starts with you. The change starts with us, and it trickles down from there. And it doesn't have to start at hospital administration. It doesn't have to start at HIPAA. It doesn't have to start with legislation. It can start with the way that we approach our patient. So take a moment, rethink how you're approaching your patients. If you're already doing it, thank you. If we can do better, and I'll tell you, we all can, myself included, let's do better. Let's continue to grow and continue to transform healthcare into what it should be, which is care for people.
Absolutely.
So, thank you, GR, one last time. Appreciate having you. And thank everybody for listening to us. Make sure you guys like and subscribe. But with that, we'll say have a great day, and we'll see you next time
on Let's Get Ethical.